Hello, good morning, good afternoon, good evening. My name is Tamam Al-Audat. I am the Managing Director of the Global Health Center in the Graduate Institute of International and Development Studies in Geneva. Thank you for joining us. Today, we are hosting a launch event for a new book, Perilous Medicine, the struggle to protect healthcare from violence of war. With us today, we have the privilege of having Professor Leonard Rubenstein, who is the author of the book. He is a professor in Johns Hopkins Bloomberg School of Public Health. We have also with us Marcin Polkowski, the head of Healthcare and Danger Initiative in the International Committee of the Red Cross. And we have Dr. Ola Abbara, who is a consultant of infectious disease in Imperial College in London and the chair of the Syria Public Health Network. The topic we're addressing today, and which the book brilliantly talks about and details and explores, is one of increasing importance and that should attract our attention more and more, both as humanitarian and as health workers. The targeting of health facilities we have seen in the past years is both worrying and under-discussed and underrepresented. When I worked in the Médecins Sans Frontières, in Doctors Without Borders, one of the most traumatic incidents we've had was in 2015 and the bombing of an MSF hospital in Kunduz by the American Air Forces. That was one that has been talked about extensively, particularly because it wasn't run by an international organization. This is one that has opened many discussions on the safety and the access and the ability of healthcare to function in areas of conflict. But obviously, this is not the first time that happened, and it wasn't sadly the last time. If anything, we've seen many attacks happen in places like Yemen and like Syria, and where, as we will hear, the International Committee of the Red Cross has been addressing this for years before. I will give the floor kindly to Professor Rubenstein, who will introduce the book and tell us about his view on the topic. Professor Rubenstein, thank you very much for joining us. It's a privilege, and we are extremely happy to have you with us.
Thanks so much, Taman, and thanks to the Geneva Graduate Institute and the Geneva Center for Humanitarian Studies for sponsoring this discussion. I really appreciate the opportunity to discuss the book, and I also appreciate Maciek and Aula joining the discussion. Let me start with why I wrote the book. I think there were three reasons. One is, while there has been increasing discussion of the problem of violence against healthcare and conflict over the last decade, I thought it was important to tell stories of what the experience was like for the people who were trying to provide care in these terrible situations. And there are a lot of stories in the book. I tell stories in Myanmar and Chechnya and Kosovo and Syria and the Palestinian territories and many other places. And I think it's important that we really humanize this issue and talk about the experience. And just to give you one story, I focus on Dr. Hassan Bayev, a Chechen surgeon who, during the wars in Chechnya, provided surgery to both sides. And in one infamous case, he saved the life of a Chechen rebel commander who had been severely injured by a landmine. And he saved the man's life And for that act and treating other Chechen rebel wounded, he was targeted by the Russians. Yet at the same time, he treated Russian wounded. And so he was threatened with death by the rebel forces. He managed to escape finally, but it was a searing experience and one in which he was doing his ethical duty and was being punished for it. And I wanted to tell his and many, many other stories. A second reason I wrote it is I think that we need to go beyond the humanitarian and human rights community to address the problem. This is a major global health issue, and we talk about the need to develop health system and universal health care, but both of those are threatened when health systems are destroyed in war. And we see the problems in so many different ways. We see the 20-year delay, at least, in eradicating polio, according to the global campaign to eradicate polio, because of the killing of vaccinators. And we see in Yemen the destruction of water facilities as well as the healthcare system led to the largest cholera epidemic ever on record by a factor of about 10, with more than 2 million people. And there's so many other examples. And I think the global health community needs to pay more attention. And finally, I wanted to try to better understand the different reasons healthcare is attacked. Not quite talking about motives, but the rationalizations for the attacks. And in doing that, I developed a framework and that goes back to a theorist named Francis Lieber, who was writing at the same time as the first Geneva Convention was being adopted in the 1860s. And whereas Henri Dunant, who was the founder of the Red Cross and the father, as it were, of the convention, urged that the principle of humanity, that suffering people are entitled to care no matter who they are. Lieber had a different view. He didn't think that morality was irrelevant, but he thought it could be superseded by military necessity. As he put it, hospitals are protected as far as the contingencies and necessities of the fight will permit. In other words, if there was a military reason for violence against healthcare, it was permitted. And that was actually incorporated into a code for the Union Army in the American Civil War. And over the course of time, his ideas were rejected because they were so open-ended and didn't really provide the kind of protection for healthcare that is needed. And yet, my view is that despite the law, which rejected his theories, his thinking continues to influence the conduct of combatants. And in my framework, I propose 5 reasons why combatants think it's justifiable to interfere with or attack healthcare. And the first is like the case of Dr. Bayev, where combatants do not want their enemies treated. They do not want their enemies to possibly come back into the fight. And they that way reject one of the fundamental aspects of international humanitarian law, which is impartiality, that you treat everyone without respect to their affiliation or even their acts. You treat them based on their medical condition. And that thinking is very widespread. It is in fact incorporated in counterterrorism law, which prohibits medical care for people who are affiliated with a terrorist organization, or actually humanitarian aid, often in areas they control. So that's the first reason. The second, which we see dramatically in Syria, is strategic reasons. We know that 600 hospitals have been shelled or subjected to missile attacks in Syria. And it appears from all the evidence that this was not only deliberate, but it had a strategic reason to force populations to move, to undermine support for any rebel forces, and to show the powerlessness of elites in society. And medical personnel were always considered elites in Syrian society. And so there was a real strategic purpose in the bombing. And we see that in some other conflicts as well. A third reason is a simple one, tactical. It's an immediate military advantage to take over a hospital in a strategic location and fire from it, or store weapons in it, or take supplies to treat your wounded, or even kidnap health workers to treat your wounded. So that's simply a tactical reason. In the moment, it makes sense to combatants. A fourth reason has to do with the precautions that are required. Now the Geneva Conventions do more than say you cannot attack health workers or a health facility or ambulances or the wounded and sick. It requires precautions. For example, the requirement to distinguish between military and civilian objects, to take precautions to make sure civilians are not subjected to violence when the object is a military one, to have proportionality in attacks. It takes a lot of work to do that, but it's required by law. And a perfect example of what happened is in the Saudi war in Yemen, was that the Saudis, it's very clear, despite urgings and training, did not take those precautions. They didn't even provide pilots with no strike lists. And so for years, this has gone on, and that too is all too common. The fifth reason we see not only in conflict, but we've seen in COVID, where politicians exploit distrust in government to interfere with or attack health workers. And in the DRC, hundreds of facilities and health workers have been attacked. There's misinformation, there's exploitation of distrust in government, which leads to violence. I should add that there are sources of restraint. We see many cases where leadership, domestic or international pressure and accountability can either ameliorate or prevent harm. And back in 2016, the Security Council passed a resolution saying you must take these actions. You must reform your laws. You must reform your military training and operational guidance in the field. You must conduct investigations. You must hold perpetrators to account, both domestically and internationally. But that has not happened. And right now we're in a situation where the violence continues. There's been international paralysis, and we need to find ways to address what is an extremely serious problem. So I'll stop there and looking forward to the comments of my colleagues.
Thank you very much, Professor Rubenstein. This is indeed the few of the ideas of you mentioned are worth keeping in mind. And one of them that immediately comes to my mind is when you talk about the effects on longer term health infrastructures and prospects in areas. So that the attacks, the way they often get portrayed in the media, if they do at all, is in terms of the immediate destruction or the victims of them. And one of the things that you very rightly mentioned is those have both the immediate and the longer term influence on the population. There have been always a problem with a single attack creates fear of health facilities if it's perceived to be a dangerous place or a regular target. It increases the health harm on the population, not only from the bombs themselves, but from the perceptions of they create, the fear they create, the migration or the departure of healthcare workers, and so on and so on. So the attack itself, it is compounded by all the side effects and creates further difficulties in recovery. I will move on and ask for my colleagues for Marchej from the International Committee of the Red Cross from the ICRC to give us a few minutes of his perspective on the topic.
Thank you so much, Tamam, and thanks to the Graduate Institute for inviting me and for organizing this event to launch what is absolutely an important book on this crucial topic. And thank you, Len, for writing this book. I read it with immense pleasure, and I think the kind of breadth and depth with which you portray the problem is something that has often been missing in the debates surrounding it. It's obviously not surprise for those who know you. You have been working on this in a focused way for the last several decades, so you're probably the best placed person to write a book like this. So thank you and congratulations again. And I think what is important about this book is that debates in the policy circles, debates about violence against healthcare often revolve around data, which can often reduce this problem to dry numbers. And I think the kind of human stories that you introduce into the topic really go a long way in, as you said, humanizing it and really portraying the magnitude and the importance of what it is that we are dealing with here. And I think another problem that we observe in policy debates on this topic is that they tend to be reductionist, and in your book you really picture the enormous spectrum of the events that unfortunately we witness across the world. I think your chapter about the motivations for this violence is also particularly important, because it's only by analyzing and understanding the motivations behind those unfortunate attacks and incidents of obstruction, discrimination, and so on and so forth, that we can begin to think about designing responses and ways in which this unfortunate situation can be countered. I think we often see this problem being treated as merely a problem of accountability and as a collection of outrageous incidents that have to be met with international condemnation and perhaps criminal prosecution if possible, as the only ways to respond to it. But I think your book says it very clearly: the arsenal of responses that we have at our disposal is far greater, and it is also good news, because it means that there is a lot that can be done in terms of technical responses, advocacy, that can have practical and concrete effect in terms of diminishing some of these patterns. And I think one of the things that you say in the conclusions is that one of the untapped avenues to address this problem is through engaging much better with ministries of health at the national level and with professional medical associations, and I couldn't agree more with this. I just recently traveled to two places that unfortunately over the years have witnessed persistent attacks against healthcare, but that have also seen some important progress when it comes to countering these unfortunate phenomena. And one is Nigeria, where we now see very strong engagement by the Ministry of Health, leadership by the minister himself, and this has had immediate effect when it comes to mobilizing the national health system to start collecting the data on the incidents themselves, but also their impact on health indicators and the health of the populations. We see strong engagement by associations of Nigerian physicians, nurses, public health researchers who all come together in order to introduce the topic of respect for ethics into the medical education in the country, who deploy concrete trainings across medical facilities, which may not be sufficient in order to counter the most egregious and deliberate attacks, but can go a long way when it comes to managing the more low-level violence, but also dealing with other negative phenomena that affect access to healthcare for those in need. In Colombia, again, we see the Ministry of Health that has been engaged on this topic for a long time. We see a network of national institutions at various levels of administration that in an extremely concerted way address the troubling patterns of violence against healthcare within this long and but low intensity conflict. Once again, the Red Cross is obviously part of the picture, and a broad spectrum of public health and medical organizations all come together. So I think, you know, what's heartening is that it is possible to bring about change and to counter the violence that oftentimes takes place within conflicts, but also within social protests or other emergencies such as pandemics. I think we should be thinking more in the global health community about how to scale up these approaches and help global policymakers that sadly have been embroiled in a paralysis, I'm sorry to say, on this topic for the last several years, how to move forward in a way that is pragmatic and actually brings results. And I think hopefully your book will go a long way in opening the doors towards positive action. So thank you once again for writing it.
Thank you very much, Marty. And I'll actually move to Ola for your thoughts, please. Thank you.
Cool. Thank you very much. So I'd like to very much thank Len for inviting me to speak today and for writing this book, but also to the Graduate Institute and Tamam for inviting me to speak. So I think my first and perhaps most important reflection is this is a book that every single person should read, whether they are a healthcare worker, a policymaker, a healthcare student, a member of the public, because it's a sad fact that we are becoming more and more aware of such attacks on healthcare, and arguably, even aside from those driven by conflict during the COVID-19 pandemic, we have seen significant threats and increases against healthcare workers. And all of it is very important for us to understand. The book itself, I have to say, grabbed me from the very first paragraph. And one of the most important aspects about it is that many of us that work in the global health or humanitarian field or who are interested in this very important topic that has been devastating to healthcare workers who are living through protracted conflict and have suffered tremendously as a result of it, is that there is a tendency at times for us to work in those areas which may be of particular interest to us for a whole variety of reasons, whether personal or professional. Whereas one of the most important aspects of this book was to take us outside of those silos and to give different historical, multidisciplinary contexts and examples which are really important, and weave that thread through all of these examples as they come about. As has been said, one of the most important aspects of this book is that it humanizes some of the stories being told. It's the stories of some of the doctors. I have to say, I know some of those doctors, and it's really important that their experiences, many of them are from Syria, and the threats, the arrests, the torture, the suffering that they face just by virtue of helping injured civilians without asking what their political loyalty would be, has been truly horrific. And now we see them, sadly, many of them have been forced to leave Syria and the surrounding countries. And we see them still, many of them working in the humanitarian field and still being driven by those same principles. And so what's excellent about this book is how it captures those motivations from these healthcare workers who haven't given up. And it drives, certainly for me personally, having not directly worked in a conflict zone, to continue. And what is it that we can continue to do? I guess it's to take the example from Len and others who work in the sphere of attacks on healthcare. I have a very mixed view about this concept of collecting and building an evidence base. But of course, I see it as tremendously important. And it's one of those things that perhaps we can do as healthcare professionals, those working in civil society organisations or in related academic work. Part of that is talking directly to those healthcare workers, as Len and others have done and are so beautifully described in this book, telling those important individual stories. Because we can all state that more than 900 healthcare workers have been killed directly during the conflict, but every single one of those has a story. Every single one has a family. Hassan al-Araj is one of the most devastating cases, and his wife was pregnant at the time he was killed with very young children. And that is a very heartbreaking reality that many of the healthcare workers, including some of those that Len describes in the book, face. And this documentation is important. It's not just in the legal sense, in the human rights sense, but it is also those stories and those trajectories of the Syrian healthcare workers, some of whom have remained in Syria, some of whom have been forced into the surrounding countries and have to rebuild their lives, and some who've been forced to go even further. And I'm obviously focusing on Syria, but I would say the same for Yemen, CAR, the DRC, and many of the other countries which has faced such direct attacks on healthcare. But for me, it's always important to remember two things. Firstly, the healthcare workers who have suffered and lived through attacks, I have to say, don't always realise the trauma they've experienced, because for them in that period of time, it was almost a normality or a given. It was happening to them and it was happening to their colleagues. And it's only when they're out of that situation that I think they realise that there is very particular specific support that they need for them to be able to continue with their lives. And many of them have chosen to continue to benefit those that they have either left behind or who are refugees, also as a result of the conflict. And the other important thing for me to reflect on and to relay is something that's time and time again said to me by local healthcare workers in a number of these countries. And I'm going to bring up the example again of Syrian healthcare workers. And for these healthcare workers, and I'm pleased to see that Len has actually brought up their stories in the book. The reason I highlight this because there had been a trend, and I think it's beginning to reverse, of really focusing on those, what we describe as heroic humanitarian workers that may go from a high income setting to provide healthcare in other contexts, so whether it's Kunduz, Libya, Syria, or elsewhere. And actually, these are people who in many ways come from a position of privilege. I knew that when I volunteered in the Ebola pandemic, that I was being treated completely differently from the local healthcare workers, and I would never face what the local healthcare workers face. And in the same way, healthcare workers that come from abroad are often, who come into these conflict settings, are often perhaps glorified or treated as heroic, whereas actually the local healthcare workers, one, bear the brunt of such attacks on healthcare in their local communities, and with the attacks on their healthcare facilities, and face it day in, day out, with little reprieve and little ability, much more limited ability to leave, or in fact they might choose to stay. And for me, that's a very important distinction, which Len beautifully describes in the book. And that's it's the voices of these healthcare workers that we want to hear more and more about. Just before I finish, I would like to highlight one other aspect, and it ties into those discussions around accountability. I don't want to name names, but I've spoken to doctors who have had to make impossible decisions around the deconfliction mechanism, and that's particularly in the Syrian context. So deconfliction is a military term which describes the declaration of coordinates for certain structures that you would hope that the enemy or both parties would be respectful of. So a few years ago, the Syrian humanitarian organisations were encouraged to share the coordinates of their healthcare facilities. And some of the organisations did and some held off. And the difficult personal and ethical decisions around this, and also I have to say, I simply cannot understand how any doctor, if I imagine I'm in their shoes, I don't know how I could make that decision. Do I share the coordinates of the health facility I'm in the hope it would be protected? Or do I not share them? And then if the health facility is attacked, I might either be accused or might feel guilty that I didn't share them and therefore it was attacked as, for example, collateral damage. And this is something that's been really important, particularly in the Syrian conflict. And it's a very stark fact that many of the deconflicted health facilities, particularly in northwest Syria, were in fact attacked. And that ties into a lot of the discussions around politics, UN Security Resolution, UN Security Council members and resolutions, whether they're respected or not, and also the different politics that's at play in a lot of these conflicts, and how they bear out in terms of the attacks on healthcare. But actually, I'm going to go back to my one reflection, which is this really is a book that everyone should read and study. I've read it once and I'm looking forward to reading it again and again, because I'm sure I'll learn more and think more about each of the aspects. And I also look forward to more discussions around this really important topic and book. So thank you.
Thank you both, Marce and Ola, for your thoughts, and that range from the effects and ways of going about the topic at policy level, but also very significantly at actively listening and delivering the voices of people who are most affected, the people who are users of that healthcare that gets targeted, and the healthcare workers in it. And if I may, Len, one of the things that differentiate the book from literature on this topic or topics within the humanitarian realm is that you have managed to put the two often seemingly impossible tasks of publishing within an academic realm, within a university press, while still being able to deliver a narrative. And you said in the beginning, you said tell stories, and the telling of the stories goes away from a frequently under-examined, let's say, way of filtering and funneling stories by external actors who choose who gets heard and who doesn't. And the genuine way you've delivered stories in this book the ability for us to actually see people rather than see statistics, to talk about something that hurts rather than something that gets just conceptualized as an academic exercise, is one of great significance. And that is not entirely common in the academic literature and university presses, where you'd often hear either very high politics or policy talk, or statistical detached language. And I think you've achieved a very significant point of being able to put us with the people that you talk about in the situations they are in, and those are situations that are significantly difficult for people who haven't experienced them to be able to imagine. And I think this is a feat in itself. The last, I just wanted to say one thing to follow on Ola's argument. One of the things that I've always struggled with working in humanitarian operations is that most of the time when medical workers are asked to work in a humanitarian situation, it is, of course, the inability to help patients who are savable under normal circumstances. Wherever you come from, you know that you can help those patients. And the failure to help them is because of the difficulty of working in an emergency, but because of the targeting of health facilities, of healthcare, of the weakening of healthcare, the sieges, the deprivation of lines of supply, and so on. But also, and while of course it is always a matter of people who get deprived of healthcare, but I just want to put it in perspective that it's not only the violence. The violence leads to situations where people, medical care workers, are forced to make decisions they aren't trained for. Decisions that are financial, decisions about triaging and excluding patients and not others, and decisions about life and death that no one should be forced to make as a matter of norm on their own, under stress, while worried about their families and without enough resources. And I think this is not a topic that is a bedside reading. And I think this book is as close as we've ever seen it become possible to reach a wider audience than the specialized one that has been interested in it. So just to add my voice to the to Marcia and Ola. But what's important is, since we have you with us here and we have the ability to benefit from your insight and your experience, where should we go? Where do you see this going? And how can we both, humanitarian workers, academics, but also the public, people who are interested and compassionate, see this and go about it?
Well, first, thanks to all of you for your kind words about the book. It's very nice to hear, of course, and for your insights. And in terms of where we go, I'll start with what Maciek said, which is that, and to put this in a somewhat broader context, attention to this enormous problem has been really restricted to the humanitarian community, some NGOs, some UN agencies, but it hasn't really reached the level of a much broader community that can make a difference. There's been very little mobilization, whether it's around the war in Syria or Yemen, or the problem as a whole. And I think we need to change that. That is kind of the most fundamental thing we can do, which is to broaden the constituencies concerned about this problem and that can act on them. And Maciek mentioned two of them, health ministers and medical associations. The World Medical Association has been very active, as has been the International Council of Nurses and some other groups. But those are Geneva-based, and they speak mostly in Geneva. And we need, at the domestic level, to have the kind of reforms in Colombia, Nigeria, and others like the Central African Republic, where there has been leadership and where these domestic organizations can really press the issues forward. At the same time, something that is very often overlooked is that the global health community is enormous, and yet there has been a lack of solidarity. We need to convey to the people working in these terrible situations, including following the dealing with the difficult ethical problems we just heard about, whether to keep a hospital open or close it because it might be bombed, but sacrificing the availability of care if you do close it. Those kinds of questions, as well as the dangers, should lead to more solidarity, to know that that people have support of their colleagues abroad. There are so many of them, and at the very least, we should make sure that their colleagues around the world know and care about them and convey that. And of course, then they can take the next step of urging policy changes at the domestic level. And what I mean by that is changing counterterrorism laws, demanding that militaries adjust their operational rules in the field at a granular level. Whether it involves checkpoints or hospital searches or targeting, that these groups can make those demands and make their voices heard. That has been largely absent. And of course, as Maciek said, it's not all about accountability, but accountability is still critical because the impunity continues. And we've had international paralysis at the Security Council because of the veto of permanent members, which prevents cases from going to the International Criminal Court, and domestic accountability. Even military investigations and court-martials are very rare. And this too has to be pursued, because as long as there's impunity, there's not going to be any incentive to change. So I think we need to, on the one hand, broaden the constituency, end impunity, and engage with ministries and other health leaders in what can be done. And we have, as Maciek said, some very good models, and we just need to pursue it. But it can't be accomplished by the players involved now. Healthcare in Danger, for example, has done terrific work, and Syrian groups have been doing remarkable data collection on war crimes there. But we need to enlarge the circle. And I think in that way, we can make some real headway, because we really do know what to do. We know what kinds of interventions can work, and we're getting a better understanding of what works for which kind of circumstances. What works for checkpoints is training soldiers, for example, and holding them to account at the command, low command levels, for making sure they let ambulances through when people need emergency care. Those are very simple. And there are other aspects of the problem where we do know what to do. And the ICRC has been terrific in providing that kind of guidance on a whole, many, many facets of the problem. But we just haven't had the pressure needed to make it happen. So I'll stop there.
Thank you very much. And this is absolutely interesting. There are two issues. One of them is the documentation and the accountability often is seen as outside the humanitarian sectors. You know, there's a double issue here, is that often the international humanitarian agencies who are more likely to be heard and listened to, at least we've learned from Syria and Yemen, than those of local organizations, are formally and insistently neutral and rarely engage in issues about documenting or testifying about such attacks in the sense that would lead to accountability. And local organizations are often, to put it mildly, distrusted and vilified often as sort of part of the conflict, rather than, there's a much bigger difficulty in accepting that there are local humanitarian organizations that are actively providing high quality and very professional care, and who have information that would be of interest and capable of providing that kind of accountability. I wouldn't know where to start, given that we've stared at crimes being committed, at attacks on healthcare being committed for 10 years now, just within the context of the Arab Spring, since those are the examples that are coming. How would we go about that? And I have no doubt that there is plenty of evidence. It's not the collection of evidence as much as what do we do with it?
Well, I think my colleagues should weigh in on this as well.
Ola, you've been engaged with a lot of the actors on the ground in Syria, as you have mentioned, and as we know about your work. How do you see their role being promoted, and any perceptions addressed?
I think you bring up a really important point, and many of these so-called local organizations, some of them are in fact not that local, many of them are expatriates and actually based in the US and Europe, but there is a wording around how we describe them. We describe them as local, and sometimes that comes across as derogatory. And you're right, they are held to far higher account in terms of trustworthiness, being accountable for the information that they provide, and also for the authenticity or the quality of the report. So if I very much focus on the topic of attacks on healthcare, they are quite often accused of bias in a way that some of the international organizations would certainly not be. For me, the discussions around these so-called local organizations, and Len will know this from many of his collaborations over the years, is actually Syria feels like it's almost changed that discussion. One, because of the range and strength of a lot of these humanitarian organizations. Many of them are expatriate, like the Syrian American Medical Society, Hand in Hand for Syria, Syria Relief and Development, UOSM, and many others. And early on, they were accused of not having the track record and governance structures, which now, given how protracted the conflict has been, they have managed to build up these remarkable structures and infrastructures in a way that many of the international organizations who often work through these so-called local actors are able to, in terms of reaching the different areas. And we know that, for example, in northwest Syria, quite early on, because of the attacks on healthcare and because of threats against international aid workers and risks to their lives, that a lot of the international organizations provided so-called cross-border aid or tried to run projects from Gaziantep or elsewhere in countries local to Syria. And of course, that's problematic. And so there's been some excellent work that Len has been involved with, which looks at how attacks on healthcare are reported in real time, what these reporting tools look like, how the information is triangulated and verified, so that later down the line, no one is able to say, well, actually, you're making this up, or this is not verifiable because an international actor hasn't been the one to report it. It's important for me and rather poignant, because when I quoted what, as far as I'm concerned, is rigorous data from Physicians for Human Rights about attacks on healthcare, I was challenged even about the integrity of their data. And this is a large international organization, and it speaks of some of the denialism that exists when we discuss such attacks on healthcare. The last comment I'll make on this is I'm in awe of many of the local organizations. Of course, Syria is the one I know the best. Our former president, Zahir Sahlul, was one of the most important voices, former president of the Syrian American Medical Society, was exceptionally important in the work that he did around attacks on healthcare. Mohammed Katoub, our former advocacy lead, was another important voice speaking up about attacks on healthcare in Ghouta in northwest Syria. And there are many others in SAMS who have been very vocal, often criticized for it, and sometimes have placed these NGOs under threat in terms of their registration. But importantly, they've been able to bring voices of many of the local healthcare workers to the wider community, even at the UN Council, in the US, and many of these institutions. So I think that's my reflection around the role of so-called local organizations.
Thank you, Ola. Marche, the ICRC is in an absolutely unique position in being the organization that is mandated by international law to protect the international humanitarian law and to provide aid and humanitarian protection in a way that no other organization can or would, at least not with a mandate that is that clear and admitted globally. How is the view from your side on what can be done, or how is that interaction between the global and the local, between an organization like the ICRC in going forward about the topic?
Yeah, thank you, Tamam, for this question. I think you raise a very interesting issue here, and there's probably an entire series of discussions we could have around this local versus global dichotomy here. And I found what you said about the credibility distinction between the international and local organizations interesting, although I tend to see the issues in a slightly different way, because when we discuss some of the most egregious examples of attacks against healthcare in some of the high-profile conflicts of today or the last decade, what I think is the problem. I don't think the problem is lack of credibility of the information that we have, because of course the information may not be complete in terms of representing the entirety of the violence that happens in certain contexts. But at the same time, we have information that is presented by local actors. We have information that is presented publicly by human rights actors, international human rights actors. We have information that is presented confidentially by other organizations, such as the ICRC. And I think what Ola described are perhaps bigger, structural issues, and essentially lack of political will, or rather strong political will, not to deal with these issues. So I think it goes far beyond any issue of credibility of data or particular methodologies. I think to a large extent, we know enough for action to be taken on many of these issues. So the problem isn't with evidence as such. However, it is also true that at the global scale, there are huge issues of underreporting, and those generate certain biases when it comes to focus also of policy debates and focus of action. I would contend, and I think Len also speaks about it eloquently in his book, that it may well be that the overall impact of those invisible low-level incidents is actually far greater than the collective impact of those high-level incidents that are documented by human rights organizations and make the front page of the New York Times. We don't know it. We may suspect that it is the case, but also the fact that the data is skewed in such a way results in a situation where a lot of efforts are focused on issues that cannot be solved easily due to the kind of political constraints that we have spoken about, whereas energy is not expended towards issues that could perhaps be addressed more easily. Here, and this is the problem that I see with data and evidence, which also partly links to underrepresentation of violence that affects local healthcare workers outside of high visibility humanitarian contexts, and so on and so forth. So this is important, and you know, for us, obviously, we're not only the guardian of IHL, but also at its very origin, the IHL came into being around this notion that, you know, the Red Cross don't shoot at the doctor, right? So this is to us really the foundational issue as an organization, and you know, organizations have different mandates. For us, the modus operandi is confidential and quiet dialogue and attempts to affect change quietly, but in a pragmatic way at the local level, and I think there's perhaps complementarity also, if you will, between various actors that are active on these issues.
Thank you. And I just to clarify, I have no doubt about the credibility of the data. My point is about the dismissibility, because exactly of that lack of political will you mentioned. Between big organizations that would be almost automatically believed if they've spoken, but are less likely to speak out about incidents, because what you say is the confidentiality and so the ICRC, which has an automatic audience that will be able to believe you immediately, but where your situation and mandate puts you less likely to speak out. And the local organizations that can speak out and probably have much more of that immediate information exactly about those low-level attacks that happen regularly, but who are easier to dismiss by actors who do not want the conversation to go on. There's that gap that doesn't always allow for information to be made available and to circle credibly. But just in being conscious of the time, if you'll allow me, I will give the last words to Len to tell us your last reflections before we thank you and go on.
First, I want to reiterate my thanks for having this discussion, and to my co-panelists. It's really been enlightening to me, and appreciate everybody's remarks, and of course the Graduate Institute and the Geneva Center for Humanitarian Studies. Just on this last point, I think there is an issue of local groups being taken seriously, but I think what we've seen in Syria and Myanmar and Palestine as well, despite attacks by the government on their reporting as biased, I think they have gotten a lot of respect from the international community, because they're becoming ever more sophisticated and accurate in their reporting, and they have used methods that are quite credible. So I think that is changing. On the bigger picture, I think there's agreement among us that if this problem can be, if not completely solved, just as human rights issues are never completely solved, it can be ameliorated in a very significant way. But we need to really engage many more actors and support health workers, and make sure the ministries of health are engaged in every other community and the global health community as a whole. And I think if that happens, we can make some progress.
Thank you very, very much. It is good to end on a hopeful note, and on a note that takes us forward and gives us a way. I will very much thank you all. We are on time, and Professor Rubenstein, thank you very much for allowing us the privilege of having this launch event with the Global Health Center and the Graduate Institute and the Geneva Center of Humanitarian Studies. Marcin Polkowski and Ola Bara, thank you very much for joining us. It's been a privilege to have you all. Thanks for the participants. We look forward to more discussions and interactions. Have a good day. Thanks.
Thank you.